Okay, good morning. I'm Lisa Bethay. I'm an anesthesiologist from Moffitt Cancer Center in Tampa, Florida. I'm going to be your moderator for today, and we're going to be talking about navigating patient safety in a locums-driven world. So welcome. As many of you know, the landscape of anesthesiology is changing rapidly with increasing reliance on locums tenens clinicians and anesthetists to maintain staffing, flexibility, and access to care. But this shift also brings unique challenges for maintaining safety, continuity, and culture within our perioperative care. So today we have three outstanding leaders who bring complementary perspectives on how to strengthen patient safety in this evolving model of care. First, we have Dr. George Tufik. He is going to be discussing how can we collect appropriate data on adverse events for locums clinicians. Dr. Tufik is an associate professor of anesthesiology at Rutgers, New Jersey Medical School, where he serves as the Director of Quality Assurance, Simulation Education, and Clinical Informatics. He's on the ASA Monitor Editorial Board and is Associate CME Editor for Education, Quality Management, and Practice Management. He is also on ASA committees for patient safety and education, quality management, and practice management. His areas of interest include patient safety, quality, clinical informatics, and trainee education. Then we'll be having Dr. Jennifer Feldman-Brillenborg. She's an anesthesiologist practicing in Washington, D.C. for the last 14 years. She's a member of both the ASA Committee on Patient Safety and Education, as well as the ASA Committee on Membership, and she serves as the president-elect of the DC Society of Anesthesiologists. She's our resident locums physician, and she'll be giving you guys her perspective on living La Vida Locums without sacrificing patient safety. And we also have Dr. Uma Munar. She's a professor of anesthesiology at Baylor College of Medicine and director of obstetric anesthesia with interest in safety education and difficult airway management in pregnancy. And she will be talking about onboarding new clinicians with a focus on patient safety. So we'll start with Dr. Tufik.
Good morning, everyone, and thank you for joining us this morning. So I'm going to be talking to you about how to collect appropriate data on adverse events for locums clinicians. So why does this matter? Locums are becoming a huge share of our workforce across all of medicine, and in particular in anesthesia. And it's not just limited to physician anesthesiologists. We're getting locums clinicians who are CRNAs and CAAs as well. The thing about it is that this transient workforce may escape standard QA and QI processes. And at their beginning, QA, QI processes are imperfect to start with. We're not doing necessarily the greatest job, and it's very, very difficult to establish a good QA, QI process. Add into that the fact that you now have locums clinicians, and it makes it all the more hard. So what are the risks of having a bad QA, QI process that's even more complicated from having locums clinicians? You might miss safety patterns. You might underreport your data. Your data itself might just not be good. And then you might just get skewed departmental data. You might be doing worse than you think, or you might even be doing better than it is that you think. What's our goal? It's to ensure that locums have the same safety accountability as permanent staff. That's really it. We're just trying to get our permanent staff and our locum staff to be aligned in terms of our QA, QI processes. So what are the challenges in collecting data for locums clinicians? You might have limited integration into your EHR and QA workflows. That might just be a standard problem that you have, and it might just be magnified with locums clinicians. A lot of times you get variability across the sites. So you might have different policies, whether or not it's required to report, and the mechanisms by which you report at different locations might be different. If your locums clinicians are confined to one facility, it might be a little bit easier to standardize that reporting process for them, but you might be in a big practice that practices across numerous locations, hospitals, ASCs, and you're deploying your locums clinicians to hospitals, ASCs, and other locations throughout your system. And now each one of those have their own reporting structures, and that makes it all the more difficult to report. Attribution of outcomes, where we get individual versus system level make it much more difficult to collect data for locums as well. People don't want to be blamed themselves. There's a fear of blame versus creating a culture of safety. So you've got locums clinicians who are coming in, they just want to do their job and they leave. They don't necessarily want to ruffle any feathers or get in trouble. They're just there as a cog in the wheel to plug in and to complete their cases, or so they may think. That's not really how they are, actually. But they might be worried about being blamed and fearing that, and that might be a reason to underreport. What we're really trying to create is a just culture throughout everything, and we've got to think about how do we integrate locums clinicians into that just culture. So with things like respecting others, being fair, seeking improvement, striving for learning, building trust, and being transparent. So what data is it that we collect? We want to look at what data it is that we collect for all of our clinicians, and it's not just limited to locums clinicians, but we've got to reiterate that this is what we want to gather for our locums clinicians as well. So you want to look at things like baseline metrics first. What's our case mix? What's our ASA status? What's our procedural complexity? And then we look at process measures. So adherence to protocols. Are the locums clinicians, just like our permanent staff, adhering to things like the universal timeout or potentially an airway checklist? And then we flip it to the other side, which are outcomes measures. We're looking at things like adverse events, near misses, and rescue events that require interventions. Then there are patient-centered measures for things like PACU delays, unplanned admissions, and then patient satisfaction if that's something that your facility does gather data on. And then those kinds of data can be uploaded and compared to national standards for things like the AQI, the Anesthesia Quality Institute that has NACOR, and compared just like permanent staff. So it's important to include the data for locums clinicians just as you would for permanent staff into those kinds of national databases. So what are some strategies for collecting data that incorporates these locums clinicians? You really want to standardize your incident reporting forms, including potentially a locum status field. Now, this is potentially a controversial issue. Do you really want to make them feel potentially different by including a locums field? And that's something that I can't answer for you definitively, but it might be something that is interesting to gather data on if it's something that's non-controversial for you, to potentially look at if there's any differences between locums and permanent staff. You might want EMR tags for provider type that filters out locums versus employed faculty or CRNAs or CAAs. But the non-controversial thing is to incorporate locums into your peer review processes and your M&M conferences. Not controversial, but potentially difficult to do in terms of logistics. I don't know about your facilities, but when we employ our locums clinicians, including CRNAs and faculty at our institution, they're not paid for educational time. For participation in grand rounds, which is where we do a lot of these peer review and M&M conferences. And we've had to go to our hospital administration and tell them, we need you to pay them for that extra hour because otherwise they're never going to come, to participate in our grand rounds because it's really important to involve them in our quality improvement and assurance processes. And they get that by participating in our M&M conferences and being part of our peer review. And then it's really important to have an anonymous reporting mechanism in place to encourage participation. It's not necessarily just limited to an anonymous reporting system, but there should always be an option for anonymity in somewhere in your reporting mechanism in order to allow people to anonymously report and not, again, feel like there's a culture of fear and blame. So when you look for patterns, you do sometimes want to look at the differences between locums and permanent staff rates of adverse events. And the reason for that is if you look for clusters of adverse events, if they're site-specific, provider-specific, or case type-specific, and you filter them between locums and permanent staff, there might be a pattern there that tells you something that you can intervene on. If there is something that's limited to locum staff and you're just figuring out with locums, it could be something that you can address, particularly with that staff. If it's site-specific, it might not be a locums issue. It might be something limited to that site. And what that does is that separates system issues from individual performance issues. Again, systemic issues, when you address those in terms of adverse events, provide the most meaningful change for your organization because it's not, hey, you did this bad thing, let's fix what you did, and then no one else finds out about it. Systemic issues really are the best ways to intervene to prevent adverse events in the future. And then if you can incorporate a dashboard with a locum filter capability, that could help a lot of times as well. So when you review adverse events, a multidisciplinary peer review that includes locums when possible, again, is the really most efficacious way to provide system-wide change. And I mentioned to you there are all kinds of logistical issues, not just limited to financial, like I mentioned at my institution. It could just be logistics that they need to be in a room at that time so that the permanent staff could go to grand rounds, for example. But when you can involve peer review with the locums clinicians as much as possible, that's the most efficacious. When you incorporate things like case-based learning, which are anonymized case discussions, that could be very efficacious. Trend reports that are presented quarterly could be one option for your group or department in order to be able to share how well you are all doing in terms of your quality. But the feedback loop that you incorporate with locums clinicians should be similar to that with permanent staff. They should receive performance feedback just like staff clinicians, and then there should be a closed loop to bring it back to make sure that whatever intervention is needed comes back and is completed. So building a culture of safety for locums is really important. So you really need to orient locums to local reporting systems on day one. This should just be right off the top of the head. And explicitly state expectations for reporting and peer review participation. If you could put it in as a requirement to close a chart if you have electronic health records, something like that is even better. And just like you encourage with your permanent staff, encouraging a just culture versus punitive approaches is really important. The thing I tell the residents on the first day of their training in their CA 1 year is, you're reporting not so that we can publicly shame you in front of the entire department, it's that we want to help make you better. This is an educational institution. We're trying to make our systems better as well. And even if it's not an academic institution, everyone's always trying to practice. That's why we call it practice, to get better. And then sometimes in your contract language, participation in QA, QI could be made mandatory. That's part of the documentation that you agree to when you take on a contract, is to complete QA, QI documentation. So what are some potential future opportunities? National registry inclusion of locums as a distinct group might be something that national reporting registries look into. Just being able to report to these kinds of institutions and get back individualized reporting is a huge step in and of itself. There might be AI detection of outliers across institutions that recognize those kinds of patterns. And there could be shared learning across staffing agencies and health systems that really integrates the data across them. So take-home messages in terms of gathering data for adverse events for locums is that locums clinicians must be a part of a standardized data capture and review. You've really got to make sure that locums clinicians are not left by the wayside and they are integrated into your data capture for adverse events. It's really important to collect both process and outcomes measures. Process measures are things like completing a timeout process, completing a checklist before putting in a central line, things like that. And then outcomes for things like PACU delays, for surgical site infections, etc. What you're looking for are patterns to distinguish systemic versus individual issues. Again, this is a universal thing, but it's important to reiterate as well with locums clinicians. We're looking for systemic things to fix, not just this person had a bad day and they did something wrong. You have to address that as well. But systemic issues are the ones that make the most impact for your organization. And safety culture really needs to extend equally to locums and permanent staff. Thank you very much. Sorry.
Hi, everyone. My name is Jennifer Feldman-Berlenborg. I'm going to be giving things from kind of the other side of the coin here, as somebody who is the locums and PRN person coming into the department, wanting to make sure that we have patient safety there, because you don't always know what you're stepping into. So how can a locums clinician ensure appropriate compliance with patient safety standards in locations that constantly change? AKA live in la vida locums without compromising patient safety. So these tips are not only useful for locums, PRN, and contract anesthesiologists, they can also be helpful for anyone who is starting a new job. These are the educational objectives of my part of things. We're going to identify potential risks specific to new anesthetizing sites, learn what questions to ask before choosing your assignment, identify concrete steps to prepare a safe environment for the patient, learn what action to take when unsafe conditions arise, and know when to cut ties. So I would argue that locums anesthesiologists can improve patient safety. My colleagues on this panel are giving the perspective from some very well-run departments with strong safety culture, which is fantastic, and it makes for a beautiful assignment for a locums anesthesiologist if things are already running really smoothly when we arrive. That's not always the case. Some locations may require locums because of high turnover, toxic culture, lack of psychological safety, or burnout of current and previous staff. Locums anesthesiologists can be an injection of morale, energy, and optimism. So this photo shows two of my sons looking before they leap off a cliff jump at the Narrows in Zion National Park. Highly recommend you go. So you want to use a reputable staffing agency or do your own homework if you're contracting directly. Use your networks. Anesthesiologist social media groups can be a good resource for vetting locations as well. Ask the staffing agency if they have any previous clinicians that went to the site that you can connect with. Go over the expectations of the location. Make sure you understand what care model and supervision ratios they are working with and that those align with patient safety. Review the types of cases, volume, schedule, and support available on site. Find out what type of EMR and anesthesia charting they're using, and if possible, get training ahead of time. So more about vetting the location. You want to ask about equipment and emergency materials. Some GI centers do not stock succinylcholine to avoid the requirement for malignant hyperthermia cart. So ask ahead of time if they have this, and if you choose to work there, have a plan that doesn't require sucks. And this is what my face looked like when I first heard that this was a thing. So malpractice insurance. This is more about your safety than directly related to patient safety, but it's important to make sure that you will still be covered after you move on to your next assignment. Occurrence-based is really what you want. While usually more expensive, it'll cover any claims related to cases you did during the coverage, even if the claims are filed at a later date. If you get claims made, you will need to make sure you purchase tail coverage. So these are just some practical things. I'm experimenting with AI-generated images, so hopefully they're a little bit humorous. So you don't neglect to find all these practical things, where to put your things, where to get food, where to use the bathroom. It'll be much easier to focus on your patients and their safety if your humanly needs are taken care of. Find out where to get quick or even free food, where to put your things, and how to get into all areas of the hospital you might need to access. Site orientation varies widely. There are some sites that you will have to actually do your own orientation. They might expect you to arrive and begin working immediately, day one, hour one. Ask about what orientation is provided ahead of time, and if possible, orient before the date you arrive. This brings up a good point that Dr. Tufik sort of touched upon when he was saying that, when you're a contractor or PRN, locums anesthesiologist, you want to get paid for your time, so it does end up being a little bit of an issue sometimes to get there ahead of time and orient, and ideally get paid for your time doing that as well. But it's something that you should address with either your staffing agency or the department itself. The list I have here is certainly not comprehensive, but these are some of the things you might not check on a daily basis, but you should know where they're stored at your new location and make sure that they're actually available. Depending on what type of facility you are working in, you might have very few of these services or backup, if any. Make sure you know what you're working with or what you're working without, so you can better decide which patients and cases are safe to do at that location. So just some examples of things you want to look into. You want to know about the backup, how you reach them, how do you call a code, where and how to transfer a patient, especially if you're working in a surgery center or a standalone GI center or an office-based anesthesia. If you're in a hospital, you want to know if you can call for an MTP or blood. How do you do that? What other services are available in that location? Do you have the capability to get labs, x-rays? Do you have an ICU? Do you have somebody to help with an emergency trach if needed? Is there interventional radiology? Is there ECMO, bypass, et cetera? It's a whole spectrum of places that you can find yourself working in, and it may not have the same things that you think are normal to have at a location. I cannot stress enough that you can't assume that things you've had at previous hospitals will be available at your new gig. There is a wide variety of supplies and skill levels of anesthesia techs, circulators, PACU nurses, and of course, surgeons. You also want to see if there's any particular protocols or cognitive aids that you should follow while at the location. Make sure you can do what you need to do with the EMR. Not every EMR system is created equal, and some require multiple applications for access. Take the initiative and call IT yourself if you need to get this info. Ideally, someone's getting you access before you arrive, but that's not always the case. So on-site day one checklist. This is a true story from one of our colleagues. You might wonder why there's a picture of a dog up here. Machine inspection reveals for veterinary use only on the back of the machine. You can't make this stuff up. Go through your usual checklist, but again, do not assume that every drug you like to use or every piece of equipment you usually have is available. A place I've worked didn't routinely supply hand sanitizer or twitch monitors, for example, but there's many other things that you might think are always there and are not there. Do what you have to do to get the things you need and don't start anesthetizing until you have them. During the assignment, you want to connect, make friends, the same thing you do in any job. Teamwork can improve patient safety. Document meticulously, of course, as we've always done. This helps make your patient safety in future anesthetics, and it protects you against liability claims. You want to make sure that everybody who needs to have your phone number has it. Get on any department emails if there are some so that you can stay up with any protocols or any patient safety initiatives. So make an impact. And as a newcomer to the department, you're in a unique position to improve patient safety. You might notice issues that entrenched clinicians may no longer notice. Things start to feel normal after you've been at a place for a while. You just get used to the way things are. Now in the toxic or disorganized or chaotic department or location, you are obviously vulnerable to bad outcomes. This is obviously stressful, but you can also look at this as an opportunity to make the most impact on the institution by helping to rebuild safety culture. So you want to interface with department leadership. In my experience, anesthesia leadership has been eager to hear how things do and don't work in your previous positions. You are a great resource to them and a window to the culture at other institutions. You want to identify stakeholders for patient safety. This can be the anesthesia chair, patient safety officer, nursing leadership, et cetera. Don't be intimidated by your newcomer status. Speak up when you see lapses in safety or dangerous conditions. Speak up in the moment, alert management, and utilize the incident report or patient safety note system. You're going to bring safety culture as part of your tool set with you. When you witness lapses in safety, first of all, call out. You're going to call out any unsafe behavior, bullying, hierarchical structures in the OR. Help build psychological safety. Secondly, report any deficiencies in equipment or processes. For example, if you notice the timeouts or proper consent procedures are not being followed. You want to utilize the patient safety reporting system as a tool to help the institution improve systems, not to blame and shame, but to help address any shortcomings in the safety systems. The privilege of being a locums anesthesiologist is that you can identify issues and call to action without fear of retribution or job insecurity. you can help to change the future, the culture, and the future, I guess, too. Put your foot down for patient safety. You are a valuable resource and should not be afraid to insist upon a safe plan and resources for your patient. First, do no harm. If leadership or institutional forces are unwilling to respond to safety concerns, your ultimate recourse is to walk away and explain, ideally in writing, why you were leaving. As one of everyone's favorite Texans, Kenny Rogers, said, you gotta know when to hold them, know when to fold them. There may be times when the organization is unable or unwilling to provide an adequate environment or support for you to safely provide the standard of care for your patient. This is one of those times you gotta know when to walk away and know when to run. And I hope you guys will indulge me on another fun AI-generated image. We can see here that the patient does not appear to be doing so well on the monitor in the back, but Kenny's winning at poker, so it's all good, right? But in all seriousness, sometimes a location is simply too unsafe overall to care for your patients. Don't gamble with your patients' lives because you are too afraid of a confrontation or losing your position. And I've actually heard almost this exact phrase verbatim at one assignment. This is the way we have always done things. Why can't you just get on board? The pressure to conform can be intense. Just remember what one of my colleagues from the Locums community said to me. It's better to lose an assignment than a patient. So in summary, choose wisely, vet the location, locate your supplies, integrate into the team, orient to the system, participate in safety culture, and ultimately move on if you cannot do the above. This is my final image here. My son's vetting the adventure location and performing a safety analysis prior to vaulting off a 20-foot cliff jump. I did not do this jump myself. So that's about it. Thank you, everyone.
Good morning, everyone. I would like to thank the organizers for giving me this opportunity to present at the ASA annual meeting today in San Antonio, and also thank all of you for attending this session. I have no financial disclosures. Locums have increased in all specialties of medicine, especially since COVID, due to attrition, retirement, or expansion of the hospitals. We are following the same trend in anesthesia practice too. The attraction to working as a locum clinician is the flexibility for maintaining a desired work-life balance. Onboarding and orientation is usually rapid due to time constraints. They also tend to work in a lot of unfamiliar facilities and diverse teams. Looking at the pre-orientation checklist, onboarding process begins before the clinician's first day at work to minimize delays and stress. Credentialing paperwork should already be tracked and ready to go. Most of the time, the locum physicians do solo cases, but occasionally they are credentialed only for supervision, and we should bear this in mind during the daily assignments. Arrange access to all necessary systems, including electronic health record, email, and any anesthesia-specific software. Provide some digital welcome information regarding facility mission, values, and leadership, along with parking access, dress code specific to the institution. Information should be sent regarding specific ERAS protocols, hemobank, or massive transfusion protocols that are used in the hospital system. Contact list with the phone numbers for clinical and non-clinical support staff should also be included. Effective onboarding for new locum physicians is crucial for ensuring patient safety. Standardized multi-step process helps mitigate risks that arise from lack of familiarity with the facility's specific equipment, procedures, and team dynamics. Introduce the new hire to the departmental leaders and key colleagues. Locums should be treated by full-time faculty, nursing, surgical, and administrative teams as full-time partners. The first day is critical, yet often abbreviated to get the clinician up to speed. Enough time should be invested for orientation as the practitioner needs to feel comfortable with the workplace. Facility tour should include a guided tour which covers the operating rooms, pre-op area, post-op area, locker rooms, Pyxis machines, difficult airway equipment. Clinicians need hands-on training for the facility's electronic health record system with dedicated support if needed. Concise overview of emergency protocols, standard procedures, and any facility-specific standards of care should also be reviewed. A mentor is assigned to help guide the new hire and serve as a reliable contact. Peer support and mentorship are useful tools to provide reference points for locum staff. Clinicians need to review facility safety protocols related to patient care, emergency codes, and dealing with critical events. They should have time to look at the anesthesia machines, monitoring equipment, and basic and difficult airway equipment. For example, where are the EKG pads, stylet for ET tube or orogastric tube, etc. It's very important to introduce the new hire to the broader OR and support staff, nurses, operating room technicians, and also to the surgeons. This will foster a collaborative team environment. Beyond the first day, ramp up cases depending on the capability of the clinician without compromising patient safety. Some clinicians are used to working and caring for healthy outpatients. They might use hefty dose of sedatives when caring for sicker patients. That can lead to adverse events if they're not used to taking care of sick patients in their previous practice. I heard of a practitioner that gave hefty dose of propofol to a patient with low ejection fraction, which resulted in respiratory arrest and a code. We need to keep in mind that some clinicians may also not be able to manage sicker patients on solo basis and need to make arrangements for the schedule by assigning a CRNA or a trainee. Initially, limit locum assignments to areas where they have been fully oriented, like the main operating rooms, before assigning to NORA sites, as assistance in NORA sites may be an issue, especially during emergency situations, as they tend to be in remote locations. Clinicians need to be oriented regarding pre-op assessments, consents, and institutional practice where the nursing team places the IV or anesthesia team. At the facility that I work, anesthesia team places IVs, unlike private practice settings. Although we made some progress in our discussions with nursing leadership to have nurses place IVs in fast turnover rooms like the ophthalmology cases. Recently, one of the locum physicians said he was ready to take the patient to the OR on his first day, and the nurse was like, "You don't have an IV on this patient." So he didn't realize the anesthesia team places the IVs. Every new hire should adhere to ASA guidelines like standardized timeouts and equipment checks in every facility. It is also important to orient the clinician regarding institutional pain management protocols. It's very important to include locum clinicians in communication avenues that was already discussed by George and Jennifer that involve patient safety, like grand rounds, care coordination huddles, and email communication. Encourage open communication within the team to ensure any patient safety issues are raised promptly. As the previous speakers mentioned, the new hire should be oriented to incident reporting system to document any unsafe practice that they witness, and hospital leadership can be made aware. Schedule regular check-ins with locum clinicians to address any concerns and provide feedback, which may be either positive or negative. This shows the organization is invested in the clinician's success. Departments should strive to foster inclusion to the locum clinicians as equal partners and not short-term help that makes them feel non-inclusive. Culture within a group of clinicians is a critical component either for success or failure of a patient safety program. Locum clinicians should be able to speak up if they identify any unsafe practice, Concrete steps are often required with transient workforce to ensure that patient safety and safety culture go hand in hand, and this process begins with clear expectations during onboarding and orientation process. Most of the locum physicians that rotate at our hospital tend to cover a lot of shifts, and one of them even wants to take up a permanent position. Locum clinicians should have enough time at orientation to get access to all the safety protocols like MTP, pain management, glucose control, and ERAS protocols. They should be able to find emergency equipment like difficult airway card, MH card, and intralipid, as they may encounter a need to use them during their practice. Solicit feedback from the departing locum clinician on their experience. This can provide valuable insight for improving the onboarding process for future practitioners. Thank you very much.
All right. We have some time for questions. If anyone would like to ask any questions to our wonderful panelists.
Yeah, thanks for those presentations. So, has anyone come up with a good solution for providing information for people starting new as well as locums at the site you need it, which is in that moment? Because, I mean, you can be handed a big booklet of information, but that doesn't give you all of the, okay, we have a bunch of ERAS pathways, and, today I'm doing a total joint. That's when I want the information. And, my thought was putting it on the computers in the ORs, but that's an IT, process and integration thing, because sometimes the anesthesia group is separate and their information is behind a firewall there. You're not employed by them. You can have difficulty accessing it if you're trying to get into the electronic information there. The hospital's similarly firewalled for accessing. And so any thoughts to how to get this, in the right place to support new people in locums when they're coming in? Because really you need the information the day you need it. It's too much to be like, here's everything, you're ready now.
Thank you so much for that question. So one of the things that I've found to be the most successful is to make sure that there is someone from the anesthesia department working with IT. In our department, that's me. And this is not easy by any means at all. And it takes a lot of time and patience to work with hospital IT, even though they're separate from us. Once you make that change that's permanent within the EHR that mandates an important safety aspect that has to be done, some kind of protocol, some kind of reporting structure, that tends to be the most efficacious in creating long-term change. So if you put something standardized in there, it takes forever, and it's really annoying sometimes to work with hospital IT, and it's really slow. And the levels of bureaucracy and tape that you've got to go through sometimes for the most basic of things. Just recently, it took me about 3 or 4 months to build in a rapid PACU discharge from our GI suite. It's silly, you know what I mean? It took about 2 steps in hospital IT, and I had to go through at least 9 layers of bureaucracy to get that done. But now that it's in there and it's a standardized process, it creates long-term meaningful change that everyone is now standardized to that practice. So for example, our adverse event reporting is a mandated step to close a chart. That wasn't easy to put in there, and it took a long time, and it took a long time to customize it and make sure that people review it, just like with our narcotics reconciliation review. Again, not easy to do. This stuff is a continuous work in progress, and it requires someone. I've got a weekly standing meeting with the IT people that I sit with them for an hour every week. It's not fun, by any means, and it's not exciting at all, and it's very menial. But that kind of structural change within the EHR, at least personally, I've found to be the most efficacious long-term, mandating and specifically requiring an action, as opposed to having to depend on handing out papers or putting up a placard or something like that. So my suggestion would be to invest the time if possible.
Can we turn? Oh, good, it's on. So I have more of a low-tech solution. I think what George was saying is the ideal solution. But in the short term, or if you don't have that that much staff or that much time to interface with tech, I would say you could make like laminated cards on a hook, hang them on the anesthesia machine, and whoever makes the schedule the night before can text the locums person and say, hey, heads up, your cases require ERAS protocol. It's available on the machine, you know, in a hook, and it's also available in the booklet that I emailed you when you started. And that way, you know, this person knows where to find it, knows that they should even be looking for it, and has it kind of readily available up front. So that should be a relatively simple, at least short-term solution.
Just in a similar vein, I'm in a private group. We have 2 anesthesia divisions. My division, we don't have any locums. I haven't had the need yet, but in the other division, I know we do bring in the locums for an orientation at our corporate facilities just to make sure they get an orientation to our, to make sure they're on board with our corporate policies and what's important to us in terms of patient safety and such. And then we also basically assign like a mentor, just as one dedicated, identified person for them to interface with, reach out to even before their arrival as a point of reference, if needed for day-to-day specific surgery type things such as that.
Thank you. Any other questions?
Sorry, one more. Just, you know, there's a little bit, I think, of a conflict when you're coming in as a locums, and I imagine, you know, just that feeling of not wanting to make trouble, and you know, and also the anesthesia group too is sort of separate from the hospital administration, just in terms of transparency and the motivation to maybe not want to report complications, especially because, you know, you want to get your next job, et cetera. And so how, you know, I know what you're saying, like encouraging people to report adverse events. And I'm on the other side, just to be clear. I work for the hospital now. And, you know, I'm trying to work with the team to improve quality and reporting. And, like, I feel like I have no visibility into what they're doing. We run reports through Epic, you know, and pull adverse events, but those have to be reported. And I feel like when I was in academics, it just felt safer. You know, we would go to M&M, we would share our complications, and we knew we were doing it in a way that we were protected. And so how to really make the team, especially locums, feel like they can safely report things in a way that we can learn from it. Not, and like you said, not in a punitive way. I just want to make sure we're doing good care at our hospital.
It's really difficult because when you look at most of the adverse event outcomes that you want to track, most of them ultimately end up being self-reported. So that is what's hard. So when you run the standardized reports for things like process measures, so things like completing a checkout, completing a timeout or a checklist beforehand, those kinds of things could be automated reports. But most of the really significant adverse events that we're looking at, reintubations or, you know, inadvertent drug delivery or something like that, a lot of those are self-reported. So that's what's really hard about what you're describing. I think it's really important to have at least one anonymous reporting mechanism. Mm-hmm. The more reporting mechanisms in general, the better. So if you've got one integrated into your EHR or you know, several that are outside, but I think it's really important that at least one of them be anonymous, so that people have the option to go and true anonymity. So for our institution, for example, we've got on every single computer a program that allows for completely anonymous reporting. You don't have to log in. You don't have to put any identifying information about anything within, you know, within the case itself that would come back to you or even necessarily to the patient. And anyone in the building can use it. You know, going down to the dude who cleans the floors, that person can report anonymously as well. So, and then we encourage everybody and tell them about that. So I think at least one anonymous reporting is important.
I think anonymous reporting is important, but I think you cannot review the case or, you know, find everything about what happened if you don't know the actual details. So,
so I would say that from my perspective as being the person coming into the department that you want to encourage to report, I mean, I think I have a background in patient safety, so it's, for me, I'm like, of course you're going to report. But for, the regular locums person that comes in, honestly, I think just saying that as part of your orientation, having a person talk to you and say, hey, listen, like, we really care about about reviewing our cases and quality improvement. We're all about, we don't do blame and shame. We're all about just reporting everything so that we can have a better system. Just voicing that is going to make somewhat of a difference. Because in my experience, nobody's even really, emphasized that to me when I even came in. But saying, okay, here's how you do it, showing them how to do it, and say, like, we really want you to do this. We're not going to be coming after you. We mostly look for systemic issues. We're not looking to blame the individual. And I think that would help.
Mm-hmm. Any other questions?
I actually have a question for my co-panelist. Can you tell us a little bit more about the situation where someone went to anesthetize with no succinylcholine?
So the situation where, I had my funny little meme of the cat going crazy, that was when I had been looking for a job and spent quite a bit this is when I was kind of new to the game and I didn't know what questions to ask, but I was going to be at a GI outpatient facility. And I don't know why it occurred to me to ask. Maybe I had heard from somebody. I said, oh, well, do you have succinylcholine there? And this is before Sugamidex existed also, so it was even more of a big deal. Oh, I'm going to have to find out about that. No, they did not have it. And when I asked around more for other GI sites that I was looking at working at, no, it's a very common practice, and all of you should be aware of that for when you get your colonoscopies. Be aware of what they do and don't have at that location, and also who's taking care of you. That's another thing you want to look into. But yeah, I never would have imagined that you'd be giving a general anesthetic without having succinylcholine available, and they're allowed to do that in some states to avoid having the malignant hyperthermia cart.
Just wanted to ask George this question about anonymous reporting. How useful is it, George?
So if they give, like you were saying, the issue is enough details to investigate. So the problem sometimes with anonymous reporting is that you could figure out who it was. So, based on the level of detail, you could be like, well, this was obviously the CRNA, or, this was obviously the circulator, or the thing that they're concerned about is what the scrub tech is concerned with. But it does make people feel better that they don't put their name or email address on it. So its utility is linked to enough information in there to be able to investigate. I've gotten anonymous things that are so vague that I can't even begin to investigate. So there's got to be enough detail in there to point you in the right direction. But if someone feels comfortable without putting their name to it, that they can as well.
Okay. Any additional questions? Well, I want to thank our panelists for their amazing talk.